We need to make sure that we're paying attention to the red flags, which are things like a clinic that recommends the same infusion to everyone. They don't review labs or medications first. So Morgan, you're right on track there. Welcome back to the Bendy Bodies podcast. I'm your host, Dr. Linda Bluestein, the Hypermobility MD, a Mayo Clinic-trained expert in Ehlers-Danlos Syndromes. I'm joined once again today by my friend, colleague, and recurring co-host, Dr. Dacre Knight, Medical Director of the UVA Health EDS and Hypermobility Disorders Center. Through our ongoing partnership with UVA Health, we're bringing you practical, evidence-informed strategies to help people with joint hypermobility and related conditions live better. Today, we're addressing some of your questions. We're going to be talking about what doctors take Medicaid, complications related to surgery, PRP, PICL procedures, IV infusions, the Zebra Club, and so much more. This podcast is for education only and is not a substitute for personalized medical advice. Stay to the end for a hypermobility hack. Here we go. Well, I'm super excited to be back with Dr. Dacre Knight, and today we're going to be addressing some of your fan questions. How are you doing today?
Doing well. Good to see you again, Dr. Bluestein. Glad to get through this exciting list of questions here we can discuss.
We get so many questions and so much feedback. So a lot of these are questions, but some are comments and things that I know people love to hear their comments read on air. So we're going to do a combination of things today. So the first question is from Brittany, and she said, I have a question for the next time you do a Q&A. I have surgery scheduled. My surgeon stated that he has operated on many EDS patients and believes the post-surgical complications are overhyped. How would you respond to this? Would you like to go first?
Why not? Sure, let's go for it. So I understand the sentiment that surgeon wants to reassure patients that the surgical indications are clear, that the outcomes are expected and appropriate for what may be the risks involved. As far as being overhyped, I don't, I think in the area of EDS and hypermobility disorders, I think we've come to understand that there's a lot of extra care we need to put in consideration of what could be consequences and risks and things. So I would generally say it's less overhyped and maybe more underhyped. And in that sense, I would say as far as surgical recoveries go, by and large, our patients do well with surgery. Yes, there are some added risks, and I'll turn to you for your expertise on what those may be. But as far as the outcomes go, the things that I see most commonly are delayed healing, most commonly. And now if there's other things like wound dehiscence and things like that and possible infections that can happen, yeah, that's certainly possible, but it's definitely on the rare end of things. So the surgeon might be right to say things are a little bit overhyped in that regard if that's the concern, that everyone's going to have wound dehiscence and that there's going to be infections and things like that transpire, because I would say the very vast majority of our patients do well. And that's what we want to see. But we, I guess, would also then say that we're being very careful about what type of surgeries we're considering and who is doing those surgeries, right? Because I would want to make sure that my patients go to the right surgeons who are careful and mindful of recoveries and response to complications that may be associated with EDS.
Yeah, and this might be an unpopular thing to say. However, I do feel like with surgeons, it's a little trickier than with non-surgical specialists because the technical aspects are so important. And sometimes somebody who might come across as not caring or almost even gaslighting, like, oh, no, it doesn't matter that you have EDS. They might technically be an excellent surgeon, but they're not as aware of EDS. And maybe they are doing a type of surgery on you that you are not really at a very high risk of having a complication. Ideally, you get both, right? Ideally, you get a surgeon who also has a decent bedside manner. But I had a family member who had surgery recently, and I went with them to their pre-op appointment. And I would say the bedside manner was not the best, but the surgical outcome was fantastic. So, I think it's a little trickier than when you are talking about, somebody coming to see me, somebody coming to see you, somebody coming to UVA to see some of your medical specialists, right? I'm sure you have surgical specialists, of course. But So I think that's the first thing is, do you feel like you're being totally gaslit and this person is, really doesn't care? And in which case, like, that's obviously a bit concerning, if not very concerning. Are they going to listen to you if you have a post-op complication? You want to make sure that they do. But I agree, most of my patients do quite well with surgery. Usually things go pretty well. Of course, if they have mast cell activation syndrome, that can add a whole nother layer. But I think the technical aspects of surgery are also so important to be keeping in mind.
Yeah, and I would agree. I mean, the technical aspects, the technique of the surgery. I mean, you talk to surgeons, and you talk to different surgeons. They got different approaches and different complication rates and things like that. So it does definitely pay off to do the homework on who the surgeon is and who you're going to see.
And volume matters a lot, right? If you go to somebody who does a ton of whatever it is that you're having done, that's generally speaking a lot better than going to somebody who just does it once in a while.
Well, it's just like you and I. We practice in the area of EDS and hypermobility disorders, so we see these things more commonly rather than the next, pain doc or an internist or pediatrician. Right? You may not see these things very commonly. So there's going to be differences of treatment strategies and things like between us.
Good analogy. I like that. I want to read a comment from Nancy, who said, I just listened to your interview with Dr. Jocelyn Wittstein, and I was a cutter when I was a teenager. Dr. Wittstein had mentioned that she sees cutting more frequently in her patients that have EDS than in other patients. And this person said, I also had anxiety and depression, which is much improved after managing my mast cell activation syndrome and taking low-dose naltrexone. I found this compelling enough to write and reveal this. Thank you for your podcast. They are so helpful and informative. This is a comment, not a question, but I'm just curious to ask you, Dr. Knight, do you think that cutting is more frequent in your patient population?
Well, it's an excellent point, Nancy, and well taken because, and I think it's brave of you to share this information, but it is something that I've certainly seen in my practice. How is it, and why is it more common? I don't really know. I don't know that we've gotten much data on this to say actually how much more common it is. We do know that there's certainly more common mental health burden of from the disease and from the associated complications and all of the things that come with that. So then that can add into some of the effects that may lead into some cutting behaviors like that. Great to hear Nancy had some response from anxiety and depression with management of the mast cell activation. That's fantastic. I guess that's what we talk about a lot. If we can target some areas which may be uncontrolled medical problems, but it helps with the kind of global psychiatric condition of it too, then it's a win-win. And killing two birds with one stone. And it makes sense because it's often misunderstood that patients are told that these problems are just psychological. Whereas we know the underlying cause, when treated, actually improves the psychological conditions of it. So I think, if we can get patients in earlier, we talk about, early pediatric care with my colleagues here at University of Virginia, but that's the idea. If we can get the care in earlier, the symptoms treated earlier, then we may not likely have as many of these mental health and psychiatric manifestations. So that's what we can hope for. But have you seen that in your practice, Dr. Bluestein?
I don't know about cutting specifically, but certainly the connection with neurodivergence, ADHD, autism, I see that a lot. And I think that, like you said, the mental health side definitely as well. And I wonder if all of that, could be contributing factors. And I notice in my patients with low-dose naltrexone, a multitude of benefits, oftentimes improved sleep, less anxiety, better pain control, et cetera. Do you observe that as well in your patients with low-dose naltrexone?
For sure. And it's one of those things that if we can find some improvement in the symptoms with something like low dose naltrexone, if it's really relatively well tolerated, and there may be some issues with pharmacy, the compounding, and things like that. But once you jump through those hoops, then yeah, it's pretty easy and straightforward thereafter. So I do find a lot of good response, more, like I said, more global response if we're trying to target something like pain or mast cell activation. I do see that there is some downwind benefit too in other areas, whether it's mental health or, other, maybe gastrointestinal, things like that, that can be of help. So it's to say that there's, and individualized approach, though, for everyone. It may not be for every patient. So we don't just kind of give a blanket prescription for anybody who walks in. Ideally, we can even find some improvement with, we talked about in some previous episodes about modalities and supplements and things like that. If we can get some improvement with non-prescriptive therapy, then that is ideal.
What was interesting when I was going through these questions and pulling out ones, and we're going to get to one from a family physician in a second, I was shocked at how many of the questions came from healthcare professionals. So that's really exciting to me because we want to reach patients, of course. We want to reach caregivers. We want to reach everybody. But when we educate and inform healthcare practitioners, it's like the butterfly effect, right? We can just affect so many more lives. So I was really excited to see that. And this next question is from Alice. Hello, Dr. Bluestein. As a family physician in Syracuse, New York, I am so glad to have found your podcast. I am really working to educate myself with your help. My question is if you know of any centers or specialists with your expertise that take Medicaid. Thank you. Does UVA take Medicaid?
We do. And that's one of the things that I like about being here is that we can be accessible to patients who are otherwise underserved. And yeah, it's a great question, Alice. And I likewise, Dr. Bluestein, I'm glad to hear that there are providers out there and, like give someone a fish versus teaching them to fish, right? That it's got compounding benefits. So if we can spread the message, uh, then others can share that. So there are academic institutions that take Medicaid more likely, less likely, private practices and so forth. I'll be the first to say, and definitely not the last, that we need more care for Ehlers-Danlos syndromes in these larger academic institutions that do provide Medicare and Medicaid coverage more widely, so that more patients can be seen, because it's a very big obstacle for some patients.
Good. Well, yeah, I was glad that she asked that question because it was like, oh, that's a really important thing to discuss. Okay. The next question is from Linda, a different Linda, of course. Praying you can give me some guidance. I was diagnosed with a rare adipose disease, Derkham's disease, by Dr. Karen Herbst, who we've had on this podcast. Recently, I've been experiencing extreme pain in the back of my neck around C2, C3. I had a concussion after falling backwards in the grocery store and hitting the metal pop shelves. I am seeing a vestibular doctor. She noticed that my left eye is not tracking properly and wants me to make an appointment with a neuro-ophthalmologist. She has headaches, tinnitus, and nausea that she describes as over the top, and she wants to know if PRP or PICL, PICL or percutaneous injection of cervical ligaments, and I should say PRP is platelet-rich plasma injections, if either of those things will help. Any suggestions would be appreciated. I have to take a leave from work at age 73. At age 73, she's still working as a paraeducator in a middle school. Oh, and then she asked if I was moving to Virginia. Do you know of any doctor that can help me? I am near Pittsburgh, Pennsylvania. Thank you. Do you want to tackle? That's kind of a multi-part question.
Yeah, there are different parts of that, but great question, Linda. And yes, Dr. Bluestein, you're welcome to move to Virginia anytime. We'll welcome you with open arms. So we love it that there's a lot of interest here. But yeah, so I guess the first question about the headaches and tinnitus and nausea, those can certainly be very debilitating. And good that when you're getting into a vestibular doctor, that's, I think, a very appropriate place to start. And certainly, if there are eye tracking issues, and that's something, yes, that neuro-ophthalmologists will be well equipped to evaluate. And so, about the PRP or the PICL, will it help? The data is growing. It looks pretty good for the PRP as far as I can grasp it. Dr. Bluestein, you might have more comments on that. But yeah, I mean, those are kind of in the armamentarium of resources that we have when we go to, we're trying to look for treatments that are not as invasive, but also a little bit more advanced than some of the kind of the standard conservative therapies. So, we want to keep Linda in the middle school doing what you're doing as much as we can. I mean, that's what we're about, is trying to keep things functioning. So I guess that's a starting point.
Sure. And in my experience, I've had a lot of patients that have benefited from either PRP or PICL procedures. Like we often say, we need more data, right? We desperately need more data. on both of those things. And with PRP, I think we have quite a bit of data when it comes to some parts of the body, like knees, for example, osteoarthritis of the knee. I think there's some pretty compelling evidence for PRP for that. But when it comes to the PICL procedure, I feel like, it's a big decision, right? You're talking about, somebody, you get a general anesthetic. I've been there to watch this being done. You get a general anesthetic and they're putting a needle, in your throat basically to access your upper cervical ligaments. And, we're talking about a high risk area. On the other hand, if you are otherwise like a surgical candidate and you're looking at otherwise getting a fusion surgery, then, you're talking about a high risk procedure there too. So I think if somebody can, and maybe Linda's already done this, work on stabilizing their mast cells, because as we talked about earlier, like that can explain a lot of symptoms. So if there's any possible ground that can be gained there, I think that's for me, like always a first thing before going to some, big procedure like a PICL or a cervical fusion surgery. But that doesn't, resolve everyone's symptoms by any means. So sometimes those kinds of things are necessary. So for Linda, do you know if when she asks, do you know of any doctor that can help me? And she's near Pittsburgh, Pennsylvania. Should she get on the wait list for UVA?
Well, you're certainly welcome to, Linda, and we're glad to. I think maybe more accessible to you though is the Penn State program at Hershey. So they've got some EDS clinicians there that can be very helpful for you. And I know they've worked with neuro-ophthalmologists and so forth. I know some of those. So that's not Pittsburgh, but it is closer than Virginia, and they may be able to. So I think that could be a good option at Penn State at Hershey Medical Center. So I hope that works out.
So you have spent a lot of time in university settings. When somebody goes to schedule an appointment, um, do they have the opportunity to choose who they're going to see, or it kind of goes to the department? I mean, it's maybe a stupid question or silly question, but or do they get assigned the doctor later?
Yeah, that's a very timely question because I had this question just about 10 minutes before this call because a patient was asking about who they might be scheduled with. The short answer is that, I mean, generally you can request to be seen by a provider. That's not unheard of. The providers themselves may have different access though and timing as far as like when is my next available versus when is Dr. Stevens next available versus when is Dr. Cohen Solomon's next available and so forth. So there may be some preferences about that, and some patients say they just want to take the next available, which is perfectly appropriate. Some say that I like the way that Dr. Stevens integrates mind body therapy in her practice. So I want to see her, so I'm willing to wait. So that's usually how it can be accommodated.
Great. I think we should take a quick break. And when we come back, we will address some more listener questions. We'll be right back. One of the questions I get most often is, Dr. Bluestein, what products do you actually use and recommend? To make that easier, I've created an Amazon storefront with many of my favorite products for joint hypermobility, EDS, POTS, MCAS, chronic pain, etc. If you're already shopping on Amazon, I would be honored if you would consider starting through my storefront. It does not cost you anything extra, but qualifying purchases help support the mission of Bendy Bodies and allow us to continue creating free educational content for patients, caregivers, and clinicians around the world. Please visit amazon.com/shop/hypermobility MD to learn more. Thank you so much for helping us continue this important work. Okay, we're back with Dr. Knight, and we are answering some fan questions today. So if you have a question, please send us a message. You can visit bendybodiespodcast.com, and maybe we will answer your question in the next episode. So our next comment is from Malini. I hope I'm pronouncing this right. Hi, thank you so much for being this voice for us Bendy Bodies. I've been following Jeannie DeBon for all these years, and it's nice to know there is a parallel of that in the U.S. Please continue what you're doing. Thank you again. So thank you for the kind words, Malini. That really means a lot. And I don't plan on stopping anytime soon. So thank you
Don't stop.
for, yeah, don't stop. So thank you for your message.
And I'll just say quickly, Dr. Bluestein, I actually had a patient who also I'd seen this morning, who had been working with Jeannie DeBon and doing the Zebra Club activities, and it was very helpful for her. So I love to see that when those improvements are found in kind of a group coordinated effort with someone who's specialized in movement therapies, it can be really, really substantial progress. And I'm glad to hear that as well from Malini.
Yeah, I should add that as well. I refer tons of people to the Zebra Club. I have, how we have our smart phrases in our EMRs. Like I have that as a smart phrase, and it's basically part of everyone's first note. So
Good to have on hand. Absolutely.
yeah, it's very good to have on hand. So yeah, what I love, I think, particularly about the Zebra Club is whether you are bedridden or more functional, you can usually get some
Yeah.
benefit.
Start
So
somewhere,
yeah,
right?
yeah,
Anywhere,
yeah,
really.
yeah,
Yeah.
yeah. Okay. Next question is from Morgan. I have HSD. She says near HEDS, which is interesting, with low blood pressure, suspected dysautonomia, histamine type symptoms, and a lot of medication/supplement sensitivity. A new clinic recommended an IV infusion containing saline plus magnesium, calcium, B complex, methylcobalamin, vitamin C, glutathione, taurine, and biotin before my blood work was even back. I already take some of these orally. In the EDS/HSD population, when, if ever, is this kind of IV therapy appropriate? Should it only be used when there's documented deficiency or a specific dysautonomia indication? And what risks or red flags should patients watch for if a provider recommends broad infusion therapies before a standard workup?
Yeah. Morgan, I think you're right to ask this question, and I would be careful. I definitely, understand your hesitation. So, and to the last point, I mean, yes, IV therapy can be appropriate and can be fine, certainly in patients who are hypovolemic, low blood volumes and having a lot of POT symptoms and severe issues with that. Um, and and especially as you mentioned also, Morgan, about documented deficiencies that can be provided by IV. And sometimes we have to provide iron supplementation, for example, if patients have a lot of kind of GI disturbance with taking oral iron. That's an example. Um, but yes, there are some concerns that if a provider is recommending that before a workup, certainly. So we always go through full clinical evaluation, visual exam, some simple laboratory assessments based on that exam, and then decide the treatment course. And that's really a standard of care, just about with any medical issue throughout the world of healthcare. I would pause for a moment on that and maybe seek a second opinion if possible.
Yeah, totally agree. And the acronym that I know people have heard us talk about over and over again, the men's PMMS that I use to describe the method that I use to treat patients. You know, so many of those are really, really important, but the first M is specifically movement, and the last M is intentionally medications, and the middle one is modalities. So I think that's another way to think about this is like you can do all the IV therapy in the world, but if you're not moving, of course, sometimes you have to do other things in order to be able to move more. But um, this is something that I think can benefit some people, as you indicated, but we have to be very cautious, and especially because the people who are often prescribing these things, they have a conflict of interest because they're the ones that are going to make money off of it, right? So you just have to really be putting your skeptic's hat on and also think about the potential complications or the risks. So there's risks of vein irritation, infection, shifts in electrolytes, changes with your blood pressure, reactions to preservatives or excipients. And you could get a symptom flare if you have MCAS, for example. So, while I wish that everybody could just go in, I wish we could do the same infusion on everyone. Wouldn't that be nice? I wish
Right.
that we could, yeah, it would actually be great
Magic
if we could,
medicine.
yeah, magic medicine. It would be great if like everyone could go in, get a little of this, a little of that, and actually get some meaningful improvement. But unfortunately, it's way more complicated than that. And we need to make sure that we're paying attention to the red flags, which are things like a clinic that recommends the same infusion to everyone. They don't review labs or medications first. So, Morgan, you're right on track there. Not adjusting doses for your size or sensitivities, dismissing prior reactions, pressuring you into packages, or not having a clear plan for monitoring and managing adverse reactions. So I think
That's
Morgan's
excellent.
yeah, Morgan's question was a really good one.
Yeah, and I mean, it looks like a lot of those components of the infusions, they're relatively benign, and it's sure vitamin C is not a huge concern, calcium, things like that. But you can still, I mean, get to a point where you're having too much of those things, and too much of anything is a bad thing, right? So, not to mention the cost and the time that's involved with it.
Exactly, absolutely. The cost is so important. And I want to read a comment from Gary, Gary T. When I saw this, at first I was like, well, who is this person? This is a CRNA that I used to work with, that I worked with for many, many years. And Gary sent a comment, love your podcast, love hearing your sweet, kind voice. Thank you for the great memories, your friend Gary. Gary, hi, I miss you. I loved working with you in the OR, and I just wanted to read that on air. Okay.
I'm glad he's still keeping track of Dr. Bluestein too. That's excellent.
I know. I was so surprised. I was like, wow, you're still keeping track. Okay. So the next question comes from Ray. Greetings. Really enjoy your podcast. I love me some good research and have appreciated how much compassionate understanding there is combined with science that really seems relatable. Lately, I've seen doctors online talk about EDS as possibly epigenetic in some cases. Maybe you can imagine the comments were heated and all over the place, but I wondered if you and Dr. Knight might be able to say something about this issue, or if you have any geneticist guests that can touch on this also. How true or wrong or merely hypothetical is this claim? Is there any basis that in EDS, no matter how it might present, that there is an epigenetic component? This issue really got my brain spinning. Even if you never touch on the specific topic, keep doing what you're doing. I love listening to you and your guests.
Well, Ray, keep doing what you're doing too, which is trying to learn more, which is what we're all trying to do. And I can imagine, I could sympathize that Ray, your brain was spinning a bit when you're going through the discussion forums and things get, heated and conflicting, and then it's just confusing, and it's like, who knows what anymore? I, and I would say there's still a lot we don't know, but we try to, just make sense of what we do and just try to, keep our composure and just keep moving forward in the patient's best interest in mind. Having said that, a lot of discussion about mechanisms and origins and causes of hypermobile EDS and hypermobility disorders really is hypothetical at this point. So, epigenetic or other multifactorial causes or polygenic causes, I mean, those all come into the picture because we really don't know. What we do know is that there have been some fairly good attempts at trying to uncover genetic mechanisms as far as causes. For example, the EDS Society endorsed the HEDGE study, which was whole genome sequencing of quite a lot of patients and didn't find a single causative gene that looked like it was a very strong candidate. There have been other groups like Chip Norris's lab at MUSC who have done some of this work too and identified some genes that are of interest, but not necessarily causative for each EDS or HSD. So is this something, being provable? It's, hopefully it is, but it's still a ways off. That's a lot of the research that we're trying to tie into and we're trying to conduct with the EDS Society at large and other institutions and help them with their biobanking and initiatives too, to try to, get as much understanding of these conditions as possible.
Yeah, love how you answered that. I know we have a bit of a time constraint today, so let's just jump into our hack before we say, see you next time. Do you have a hack for us by any chance?
Well, I think it's a great one pointed out by a previous listener, which is if you are, looking at different clinicians and these are growing in the world of EDS and HSD. And so if you are, I think you summed it up even better, Dr. Bluestein, but if you're approached without, clear workup and an intentional workup of symptoms of EDS or HSD and you're given kind of prescriptive therapy, then I would definitely take a pause there. And whether it means going back and listening to some more Bendy Bodies podcasts or, talking to friends or family who are knowledgeable about these conditions, but it's probably a point where you need to get another opinion. And I know these opinions are kind of few and far between, but it's better safe than sorry. Your safety is of utmost importance.
Yeah, I love that hack. Well, thank you so much for joining me today. And to everyone listening, please visit bendybodiespodcast.com and submit your questions, your comments. We love hearing from you. And Dr. Knight, thank you so much for joining me again today. And we will see you next time on the Bendy Bodies podcast.
Thanks so much, Dr. Bluestein. Always a pleasure.
I'm super excited to tell you about the Bendy Bodies boutique. I am so proud of our fierce styles and flexible designs. These are created by hypermobile artists for hypermobile shoppers. There are so many fun items from clothing, accessories, home goods, and my favorite are the bags. I especially love the Weekender tote with one of the EDS Tough designs. Whether you're shopping for yourself or someone you love, there's so many options to choose from. A portion of the proceeds goes to support EDS nonprofit organizations. For more information, please visit bendybodiesboutique.com. Thank you for listening to this week's episode of the Bendy Bodies podcast. If you'd like to go deeper, I share additional education, clinical insights, and resources in my newsletter, The Bendy Bulletin, which you can find on Substack at hypermobilitymd.substack.com. You can also help us spread the word about connective tissue disorders by leaving a review, sharing this episode, or sending it to someone who needs it. These small actions truly make a difference in raising awareness about these conditions that are still widely misunderstood. And don't forget, full video episodes are available every week on YouTube at Bendy Bodies Podcast. As many of you know, my passion is helping people better understand and navigate symptomatic joint hypermobility. In addition to my clinical and educational work, I offer one-on-one coaching, professional mentorship for healthcare professionals, and expert witness services. If you'd like to learn more, please visit the services page at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, X, and LinkedIn, all at Hypermobility MD. As part of our collaboration with the UVA Health, EDS, and Hypermobility Disorders Center, we also want to share a few helpful resources. For questions or appointment inquiries, you can contact them at ruvaedscenter@uvahealth.org. That's the letter R, UVA EDS Center at uvahealth.org, or call 434-243-8200. Our incredible production team is Human Content. You can find them on TikTok and Instagram at Human Content Pods. We love bringing on guests with unique perspectives to share. However, these unscripted discussions do not necessarily reflect my views or opinions. Furthermore, perspectives expressed within Bendy Bodies media, including this podcast, do not reflect the views or opinions held by Human Content, Inc. Although we may share healthcare perspectives on this podcast, no statements made on Bendy Bodies should be considered medical advice. Listening to or watching this podcast does not constitute a doctor-patient relationship. Please always consult a qualified healthcare provider regarding your own care. For information about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, HIPAA release terms, or to get in touch with us, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.